I approach this topic primarily from the perspective of my clinical experience as somebody who deals with treatment-resistant depression. So I'm going to give you kind of that perspective on this. As Cam said, I co-direct a lab at UC San Diego with my wife, Dr. Mishra. She is trained as a cognitive neuroscientist. I'm trained as a systems neuroscientist and a psychiatrist. And we kind of try to bring together a combination of neuroscientists, engineers, and clinicians. And our main goal is to try to develop translational neuroscience. So neuroscientific approaches to improving mental health. And, between the two of us, we try to do research in preclinical animal models with local field potential single units, and a lot of individual interventions, community interventions, and try to kind of cover a broad range. And that's why it takes two of us and not one of us. My talk is going to be mostly in three parts. So I'm going to be talking about some of the challenges we have in treatment-resistant depression and mood disorders. And the nutshell is they're not very effective treatments. We have this one-size-fits-all approach. We focus probably overly much on symptom reduction versus some of these other things that Fred and others are talking about. Cognitive flexibility, behavioral change could be potentially more important as a focus of treatment. Part two is some of the ways we're approaching how to potentially move the field forward. And part three is how do I feel like psychedelic medicine fits into this and kind of fits into this from the perspective of somebody who's dealing with treatment-resistant depression in particular. So just to start off with, when we think of what is depression, right? So starting with Arthur Kleinman, who says modern physicians, of course, this was back in 1978, but it's still true, diagnose and treat diseases, abnormalities in the structure and function of body organs, whereas patients suffer illnesses. It's the human experience of sickness that really matters. It's really what we should be thinking about. We have a biomedical model of illness and treatment. What does this biomedical model consist of? Well, depression as an illness is a set of symptoms and behaviors that co-occur together, right? Is this an entity? It's hard to know what depression is, but this is how we categorize, this is how we group it. The way our biomedical model currently works, etiology is multifactorial. It's hard to pin down one cause of depression for everybody. We know this. And it's somewhat irrelevant to treatment, which is probably not how it should be. Our treatments tend to be fairly algorithmic. I'll talk a little bit more about that. But it includes both a psychological and a biological model, and this is where psychiatry is very different than most other fields of medicine. If we think about psychological models, we think about maybe depression is a psychological state associated with maladaptive, affective, and cognitive processes. And again, Fred was talking a little bit about this. There may be many psychological, environmental, developmental issues that come up and can cause people to have different aspects of depression. And actually in the psychological model, the treatment is guided by the clinical formulation, like whether we use cognitive behavioral therapy, psychodynamic approaches, interpersonal therapy. It's guided by the formulation of what may be going on for that person related to the depression. We also have a neurobiological model for depression, right? And we've heard a little bit about that, and Connor will tell us a lot more about that as well. But this idea that depression is associated with neural changes, brain changes. It could be at the level of synapses. It could be at the level of circuits or networks. Helen Mayberg has a kind of a network level model. So there's different levels at which we can think about dysfunction, but there is a kind of neural perspective or a neural model for this. Interestingly, and I think this is where the future of psychiatry is going to change, but right now our treatment is empiric, it's evidence-based, it's guided by algorithms and not by maybe measurable neural dysfunction. So this is, I'm just talking about where we are right now, right? So if we think about the theoretical perspective of what depression is, we might say, hey, depression is this entity, it's this illness, it's clearly separable from healthy individuals who don't have depression. And the truth is that's not really true. If you really think about just depression scales and having at a population level, what does the distribution of symptoms look like? It tends to lie in a continuum, and we make an arbitrary cutoff or threshold at the level of some level of symptomatology, which we say, okay, now you have depression. But it tends to be arbitrary, and maybe a better way of thinking about depression, at least, is that it does lie in this continuum of severity. I think clinically, when we approach depression, we usually approach it probably from two axes. The severity axis is one of them. So we think of mild, moderate, severe depression. But the other important axis that we're always thinking about is the axis of, we'll say, chronicity or treatment resistance, right? So a lot of when we think about how do we decide what treatments to use or what approaches to use, whether it's at an individual level or even at a public health or systems level, it's kind of thinking along these two axes. If we think about treatments along these two axes, you might say, okay, at the first quadrant, the one where you have mild to moderate levels of depression, not a lot of chronicity, so maybe episodic, behavioral and lifestyle medical approaches probably make the most sense, right? This is where meditation or mindfulness approaches come in. Exercise has a low to moderate effect size. Nutritional approaches. Once we get more into the moderate or severe level of depression categories, we start thinking about more medical treatments or psychological treatments, psychotherapy medications. A lot of what I do in my clinical job is at this upper end. So we think about, for folks with higher levels of chronicity, TMS, ECT, vagal nerve stimulation, ketamine. And I'll tell you a little bit about my perspective for where psychedelics fit into this, but I think there's ways in which psychedelic medicine can fit into all of these different quadrants. And then the last is folks that maybe they have chronic illness, but we're trying to get them a little bit better, right? So I'll tell you a little bit, before I dive into some of the research, I want to review a little bit about what is our real world data. So this is data from our VA ketamine clinic. I'm just going to show you first a little bit about results we've gotten with the intranasal S-ketamine. We've been doing that since about 2018 or 19. And we get so this is non-controlled, right? Everybody's getting S-ketamine here. We get a significant change in both PHQ-9, so depression, and a significant change or improvement in PCL5 or PTSD symptoms. We're basically treating folks in that third quadrant, so high levels of chronicity of illness, often people who have tried 4 or 5, up to 8 or 9 medications, have had symptoms for a decade or more for many of them. And generally, and I'll talk about this a little bit, but generally moderate to high levels of severity, and about 80% comorbidity of depression and PTSD. So despite the fact that we get a significant improvement, we're not getting major improvement. So if you look at the PHQ-9, we think of mild depression as less than 10 on this, and no depression is less than 5. And there's very, very few people that were getting to that even mild or no depressed state. We're taking people who have severe depression. We're reducing on this PHQ-9 score scores by about 4 to 5. With PCL5 scores, we're reducing them a little bit more. But only 14% really show a clinical response. A response here means a reduction in PHQ-9 by 50%. So even with intranasal S-ketamine, which we think of as this, very potent plastogen, all of these things that we've been talking about, we're not getting the best real-world results. We do see an interesting partial decoupling between responses to PTSD with the PCL5 and depression, PHQ-9. Something we think a lot about depression, ketamine, the effects of ketamine depression, are that it's a rapid antidepressant. It works very quickly. We see this too. We see most of the benefit on depression scores in the first or second treatment. Interestingly, with PCL5, we see much more of a linear trend. It seems to take longer to get the full benefits on PTSD symptoms. And we see some decoupling. So if you group folks by how well they respond on depression, to a very small antidepressant response, moderate, or a large, we actually see in the small and medium antidepressant groups similar effects on the PCL5. So even folks that have no antidepressant response, some of them still get a reduction in PTSD symptoms. We looked at a few other things. One of the things we looked at is sleep apnea. Why is sleep apnea relevant? Well, sleep apnea prevents or reduces slow-wave sleep. Again, referring to David's talk and Connor's talk, a lot of how we think ketamine works is by increasing the number of spines. And part of why slow-wave sleep is important is there's this model that slow-wave sleep helps with homeostatic plasticity, helps to kind of regulate our spines in particular ways. And there may be interesting dynamics about increasing and decreasing spines that helps to explain how ketamine might work. We found that sleep apnea does not affect the antidepressant response. So you get the same level of antidepressant response, but it does affect the PTSD response. So people with higher levels of sleep apnea have a reduction in this slow linear response to PTSD symptoms. So this is just a little bit to say that even with some of our most effective treatments, we still have a ways to go. We need new treatments, we need better approaches, and even if you think about something like ketamine, where we have a maybe synaptic model for how it works, there's still differences in how it affects different psychiatric disorders that tells us we need to know something more about what's going on. We have one other thing I'm going to tell you about our clinical data, and then I'll get a little bit more into some of the research we're doing separate than this. So this is now a larger sample of about 130 vets. That it's a mix of esketamine and ketamine. What we wanted to start looking at, this is with a medical student, Eric Miller, who's about to start his residency in a few months. We started looking at, or he was actually got very interested in what are the single item responses and how do those map out to changes with ketamine. And what he found is actually, and this is, I think, encouraging, some of the core aspects of depression, depressed mood, concentration, anhedonia, are the things that improve the most. So what I'm plotting here is the negative slope. So the more negative it is, the more of a response there was to ketamine. And what you can see is the things on the left are the things that change the most with ketamine. So ketamine helped the most with these core aspects of depression. One of the things we were interested in, and I said to Eric, hey, what if we find that there's some predictors using this PHQ-9, using the single item scores, is there anything that predicts whether somebody's going to respond well? And he ran an initial multivariate logistic model and did some cross-validation, so kind of very simple machine learning types of stuff. And our classification wasn't very good, not surprisingly, right? We got a little bit better than chance, but not great. So then he started tuning the model. He came up with this idea of, what if we don't care about classification per se, but it might be enough to say, hey, we can rule out some people. Just based on their baseline symptoms, PHQ-9, can we tell some people, if they don't fit the right pattern, you're not going to respond to ketamine? We tried to do the same thing to predict using baseline symptoms if you're going to respond. We were very bad at predicting who was going to respond, but not horrible. I mean, not in a way that I think is probably clinically meaningful. We could get about 20% of the folks that went through our clinic, we could predict just based on the baseline PHQ-9 that they probably weren't going to respond using this logistic regression model. And one of the things we found, so the depressed mood was one of the highest predictors for this. And depressed mood was a predictor in the sense that if you had low levels of depressed mood, you were not likely to respond. The other things were eating and some other symptoms. This is the pattern of symptoms. But the take home was really probably this slide. If you group the people that we were accurately able to predict were not going to respond to ketamine, they actually had very low levels of PHQ-9, the summary score, and they had very low levels of depression. So this is just another way of saying when we think of depression, we need to start thinking much more carefully about what we mean. What do we mean when we think of reductions of depression? Specific symptoms are probably a better way of thinking about it, specific clusters of symptoms, and different agents. And probably what we're going to find out with all of these various psychedelic agents is different domains and symptom clusters of depression may respond very differently to these various agents. So what is my take-home summary? Right now, we have multiple models of depression. We think of them as a spectrum. We kind of map on different types of treatments depending where people lie along these spectrums of severity and chronicity. We need to do better at getting more efficacious treatments and at really identifying who should get the different types of treatments. I'm going to talk to you a little bit about two specific ways we're starting to use EEG and other types of data to try to find personalized markers for this. I'm going to talk about one study we used EEG to find markers of suicidality, again, looking at single item scores rather than depression per se. And I'm going to talk to you a little bit about mindfulness, default mode network, and ruminations. And I think both of these are relevant to kind of the larger picture of how should we use psychedelics and how do we most effectively use psychedelics. So just first, I'm going to talk about this EEG marker of suicidality. This is kind of a machine learning or classification project, right? So one of the things that when Jyoti came to UCSD, she said, you know what we're missing in this field? We're missing a neurocognitive battery. A lot of people have run cognitive batteries. This has kind of been done for a long time. People also do EEG on specific tasks. But what if we had a systematic approach where we have a set of cognitive tasks that measure behaviors across domains that we generally think are important? And she set up about 6 different domains. Inhibitory control. So that's kind of a task where you either you're faced with a cue and you either have to respond as quickly as possible or withhold a response. Go, no-go task is another way of thinking about that. A task of interference processing, a task for working memory, an emotion distraction task, and a reward processing task. She set up and optimized these tasks such that we could get EEG markers for all of them, so it wasn't purely cognition. And we just started running these on as many people as we could across adolescents, older adults, healthy folks in our clinic. We just started trying to collect a lot of data. This particular project, what we did is we took people who responded as a positive on the PHQ-9, the question related to suicidality. Anybody who said they had any level of suicidality, we include them in our positive group. And then we age, gender, and summary score PHQ-9 matched them. So they all had the same level of depression, but the only difference in terms of the PHQ-9 was some folks said, yes, I have suicidality, and other folks said, no, I don't have suicidality. We have a student, Jason, who was working with us, who's a bioengineering student, and he said, okay, let's see if we can use EEG data, and we took each task separately, and we said, on any of these tasks, can we get any level of classification for the folks that have suicidality? So more than 0, 1, 2, or 3 on this questionnaire, versus folks that don't have suicidality. And very interestingly, we did find very good classification, sensitivity of 94%, specificity of 86%. So this is actually very good for an EEG study. It's a small sample, 38 in each group, but it's a well-controlled sample in the sense that a lot of these suicidality questions, depression isn't controlled for, and other things aren't controlled for when they do these classification studies. So we found what was interesting is it was very much only on this one task. It wasn't on any of the other tasks, and it's one example of, again, what Fred was saying. It's a validation that cognitive neuroscience is actually really important, that resting state activity or the wrong task may not tell you the information you need to know for different things. Just to get into a little bit more, what were the neural predictors? So one of the approaches we use is we take scalp EEG data, We apply these source localization models to the EEG data. We define in networks, primarily from the fMRI literature. We have these kind of like fMRI-based networks. We source localize the EEG data to those. And the neural activity that there's basically, on this inhibitory control task, the neural activity that really helped differentiate folks with suicidality versus not occurred primarily on errors. So this inaccurate visual, inaccurate singular opercular network, inaccurate default mode, and inaccurate ventral attention network. The activity in these 4 brain regions, when subjects made a mistake, is what was sufficient to provide us the classification accuracy we needed. We didn't need any other task. We didn't even need neural activity from any other parts of this task. This one part of this one task provided all of the classification we needed. Here's the actual activity from these different networks, and you can see why our classification is pretty good. We see actually very good separation between individuals with suicidality and individuals without suicidality in these different networks. This gets into, I think, one of the aspects of how we think we should be moving forward in all aspects of psychiatric clinical care, is starting to use these scalable approaches or neurocognitive mapping approaches to identify potential targets for treatment. And here I think our target would be, and again, Fred kind of alluded to this, but the sensitivity to error, the sensitivity to negativity. We think that's probably what we're mapping onto, or what we're identifying to with folks that are suicidal or have some level of suicidality, or just more sensitive to this negative signal that they get on a standard cognitive task. Part of what we're interested in is not just looking at these aspects or physiological circuits in humans, but in preclinical models as well. And we had some references to that, but what is a preclinical model for depression? Well, it's hard, right? Because animals have different types of and forms of cognition than humans. Humans, when we think about depression, we think a lot about meaning and purpose and all of these other aspects that we don't really know how to measure in preclinical models. That being said, preclinical models have been fundamentally important in how we understand how various treatments might work at a circuit level. And we think electrophysiology could be kind of a bridge between animals and humans. And so we're using local field potentials as a way to map onto EEG data. And this is just to show that some of the same physiological properties that we measure in humans, we can measure in animals. And on the same go, no-go task, the same impulsivity task that we were looking at in humans that we think is a marker for suicidality, we have an animal model of that same task, and we're measuring very similar physiological circuits. The second thing I wanted to talk about, and this gets to kind of where psychedelic medicine is very interesting, I think, for psychiatrists, neuroscientists, is this connection between neurobiology and phenomenology and psychology, right? And people have talked about this in various ways, but the default mode network is one of these brain networks or a set of brain regions that seem to be very involved in a lot of processes, and psychedelics affect the default mode network. The default mode network, is fundamentally this set of brain regions that's involved in many things, but we'll say interoceptive processing. And when people are planning for the future or thinking about the past, maybe even in highly creative states, you see more activity in the default mode network. However, we also see more activity in the default mode network when people are ruminating about things. When people are more depressed or more anxious, we see more activity in the default mode network. We think mindfulness, so getting back to this idea of mindfulness, could be a default mode network targeted intervention. We're not the only ones who think that, but we think that's one of the ways that mindfulness might work. And one of the reasons why mindfulness approaches may work for depression is the degree to which you can actually affect default mode network activity. And it connects this phenomenology of depressed mood with the psychological processes of ruminations and this neurobiological approach of default mode network. So how did we want to study this? So mindfulness is a very difficult thing to study, right? Most of the time it's subjective. People are saying, you can ask questions like, how mindful are you in your daily life? How distracted do you get? People can try to do other ways of testing this. We developed this cognitive task. In this task for mindfulness, we basically have people close their eyes and just tap every 2 breaths. So it's a breath counting style task. And what we can do with this is we can actually look at when people respond fairly consistently. So every 2 breaths, if they're mindful, if they're paying attention, they'll respond with a pretty consistent tap interval. If they take a lot longer, we think, oh, they probably got distracted. And anybody who's meditated knows that meditation and mindfulness is primarily your mind wandering. And the art of meditation is bringing your attention back to what you're supposed to be paying attention to. When we look at performance on this task, so how consistent they're responding, we see very good correlations. Again, this is the advantage of this neurocognitive battery. We see nice correlations or relationships with many other aspects of cognition across all these other tasks. So we think we're tapping into or measuring something important. When we look at the EEG activity, we see that there's primarily activity in the alpha band and alpha oscillations. So we focused on activity in this alpha frequency, this 8 to 12 hertz activity. And when we look at the effects of distraction, so now we're looking at activity prior to response, either on trials when subjects are paying a lot of attention, responding consistently, or very distracted. What we see is when people are distracted, there's a lot more activity in their brain. We see more activity almost everywhere, but it seems to be particularly concentrated in some of these default mode network regions. One of those plots is supposed to show a bunch of significant effects, but you can see it on the left. Basically, we see a lot more and highly significant effects during distraction, primarily in the posterior default mode, and the medial temporal default mode network regions. So we do think that we have a way of measuring a neural level of distractedness. And what we also find is that on this task, greater suppression of the default mode is related to connectivity with the frontoparietal network. So some of these executive control regions that we think are really important in regulating the default mode, that we think psychedelics act on or induce plasticity on, we think that mindfulness is a way of looking at connectivity between them or strengthening connectivity between them. So there's 2 other things I want to show you. The first is we wanted to see if activity on this task mapped onto something beyond the task, right? So part of what we wanted to know is, we said there's more activity during distraction on this task. We think this is related to their levels of real-world mindfulness, and this is what we did. We asked everybody, we had this mindful and awareness scale, and we said, is there any relationship between default mode network activity? And we looked at everywhere across the brain, so we didn't pick and choose, and we found a significant whole brain corrected effect primarily in the posterior default mode. So the same region, which showed more activity when subjects were distracted, also showed a negative relationship with real-world level mindfulness. More activity here on distracted trials was related to less real-world levels of mindfulness. We found the same kind of relationship in individuals with depression. We had the PHQ-9 scores again for everybody. We looked at no depression, mild depression, moderate depression. We grouped people in these different categories, and we found folks with moderate or above levels of depression showed more activity in this posterior cingulate cortex on this task. So before I get into the rodent data, so essentially what we think we have here is a way of connecting a phenomenological aspect of people's real-world behavior, which is mindfulness, with something we can measure in the brain. and we connect it to some kind of connectivity between this default mode network we're measuring and prefrontal cortex. And the last part, I'll tell you how we think this is, or why we think this is relevant for the general psychedelic work. But one of the other things we're working on right now is, again, connecting the idea of how do we use preclinical models to test the effects of these things that we can't really test the effects of. How do we understand psychedelics in rodents, right? We can't. But now we have some kind of traction. We have an inroad here. We have a physiological parameter, which is alpha oscillations in the default mode network in humans. So we started looking, do we see any evidence of default mode network-like activity in animals? We measured activity in the prefrontal cortex and in posterior cingulate cortex and a bunch of other brain regions. We have animals performing essentially a visual attention task. And we wanted to see when the prefrontal cortex is activated, do we see any evidence of suppression in any of the regions that we would think of would be like a rodent version or analog of the default mode? And we actually found this, and we found it in the same frequency, this alpha frequency that I was just talking about in humans. Here's kind of the full map. Basically, where I highlighted in red is the alpha frequency, 8 to 12 hertz. In prefrontal cortex, you can see yellow. And anywhere you see yellow is activation. And all of the blue is where you see suppression or deactivation. And this is very analogous to what you see in human fMRI literature. It's where we think we actually have an analog of default mode network suppression. We think this could be a good use case or tool base to start testing out the effects of different medicines, like psychedelic medicines and agents. And rather than look at a synaptic marker, like change in synapses, we can look at a network marker, such as default mode network changes, and use that as an analogous way of testing in a preclinical model different pharmaceutical agents. And this is just the human EEG data. The last part I'm going to talk about is, again, thinking about behavioral and lifestyle-based approaches for depression. So I'm going to put it in this bottom category, right? Cheap, scalable, low side effects. I'm going to tell you a little bit about how we think about these and how, again, we think using these approaches, we can enhance the effectiveness or the efficacy of psychedelic medicine. Because getting to Josh's talk about the hype versus the hope, I think no matter how effective we think these medicines are going to be, they're probably not going to be as effective as we want them to be. And the only way to make them as effective as we want them to be is to combine and use an integrative approach, where you have a medicine which is engaging in plasticity, and you're using either a cognitive training or a cognitive learning or a behavioral approach to encourage or enhance behavioral change. So just thinking about lifestyle-based interventions, right? There's a bunch that are out there. There's kind of social interventions, increasing joy or gratitude. Exercise is a very important one. Insomnia-targeted or sleep-targeted agent. We talked about mindfulness, dietary interventions. There's a whole bunch of things we as clinicians can recommend. Is that time? Oh. No, I have some time left. Okay, great.
No, I was nodding.
So the problem is, I love to tell people to do everything, right? If you come to see me, I'll say, hey, you need to exercise more. You shouldn't. Why are you going to McDonald's for every meal? We need to think about this. You don't see anybody. We need to increase how much you see people. And you can't tell people to do everything. It's not really feasible. So I generally actually don't do that. I was kind of joking, but I try to pick and choose one or two things, and I just kind of guess, right? And it's not great. How do I know that exercise is actually going to make a difference for somebody? And sometimes I'll talk about exercise, and somebody who's very depressed will say, Doc, I exercise an hour a day, 5 days a week. The exercise is not going to help me. I'm already doing enough. I'm like, okay, thanks. So part of what we wanted to do is actually get more objective about this, to actually start giving people ways of, we measure people's activity, exercise. We ask them a bunch of questions about their nutrition, but we don't do this once. We do this serially. We get a bunch of data, And at the same time, we're getting a bunch of data about people's mood, right? So we're trying to find a way of relating people's actual activities and behaviors with how their mood is. And we use these, what are called nomothetic machine learning models. So within that one person or N of one machine learning model, to try to find what are the behavioral things that people do that are most related to better mood versus worse mood. This is not an intervention, but I'll tell you, we have an intervention we've developed around this. So this is just the first study that came out of this approach, where we said, how good are we at predicting people's mood based on all of the variables that they tell us and all of the variables, objective variables we're able to get. We give people a smartwatch, so we get some objective data, and we map it onto all of this subjective data they're giving us. And for some people, we can do pretty well. Across individuals, there are some individuals we're not very good at predicting their mood at all. So, of course, the machine learning model doesn't work perfectly. For each person, we test a bunch of models, and we find the best one. But even the best model in some people just doesn't do very well. That first study was published in 2021. And since then, Jyoti and I have been developing an intervention around this. And what does the intervention look like? It looks very similar, but the step 2 is we say, hey, look, this is what your machine learning model says are the things that are most related to your better mood states. We want you to do more of those things. If it's better sleep, we have a CBTI-based type of intervention. If it's exercise, we try to get you up to 150, 180 minutes of exercise per week. If it's nutrition, we focus on kind of a Mediterranean healthy diet plan. And sometimes for people, it's interpersonal relationships. And then we have this positivity plan that we've adapted from one of the psychology colleagues that we have at UCSD, Charlie Taylor. So here's an example of one of our subjects' data, and we rank order all of the things that go into this machine learning model. And based on that, we select an intervention that would be best suited for them. This intervention is very scalable. We have a quote-unquote coach model, so we have a plan for each of these interventions, but they meet with a coach 15 minutes a week, and I actually think that helps to get a lot of people's buy-in to continue to do these things. And we might say to somebody at the first session, hey, based on your model, the things that are the top predictors of your better mood state are sleep or positive connections with other people. Which intervention plan would you like to be in? We signed them up for a 6-week intervention plan. And here's our data so far. So we're about 6 or 8 months into this. It's an open label. We don't have a control group yet. We're just trying to work out how do we operationalize this. Out of the 15 subjects, we're actually seeing nicely good trajectories of improvement for all of them. You'll notice we're not taking in this initial pilot very severe, highly depressed people. We focus this intervention on kind of the lower depressed. So PHQ-9, I think we have an inclusion criteria, PHQ-9 less than 15. So this is in the mild to low moderate depressed folks. But it looks like, at least in our initial data so far, is looking very encouraging to us that matching people to an intervention based on their own data may be a good way forward. Okay, so I'm at a psychedelic conference. How do psychedelics fit into all of these things that I've talked about so far, right? So first of all, our population is similar. Whether we're using psychedelics or TMS or SSRIs, it's the same distribution. I'm going to start with this simple axes, these 2 axes, right? How might we think about psychedelics? Well, you might think, and going to Dr. DeWitt's talk, the microdose or recreational folks that benefit from that may be in that first category of folks, right? That's where maybe the large majority of people actually are. And they're using things more for personal wellness, which, if it works, caffeine helps. It kind of fits into this larger framework of folks like that. If we get into David Olson's work, you think of perhaps non-psychedelic plastogen, so agents that increase plasticity, as fitting into or potentially even replacing, that would be a great thing, I think, some of our current pharmacotherapy, right? It's very possible that that is not enough. And this is where you start thinking about psychedelics or plastogens plus. What is the plus? The plus could be psychotherapy. The plus could be things like what we're developing, digital meditation tools. The plus could be lifestyle medicine approaches. It could be all of these above. And I put these in categories, but the truth is, once you start thinking about the additions, once you start thinking about psychedelics as a way of inducing plasticity, the next goal is, where do we induce the plasticity? How do we increase behavioral change around that? I have a few more slides and I'll be finished. This is just to say that we think that for us to be able to make forward movement in this area of psychedelic medicine as applied to mood disorders, we should really be thinking from the get-go of something like an EEG cognitive battery approach, something where we get a lot of data and everybody who's getting these, and we're able to put it together in ways. I like EEG because it's scalable. We can do this in a lot of folks. It's not going to cost $500 or $1,000 for everybody to do it. So you can imagine operationally implementing this in clinics very easily. We think, we have a digital meditation approach to this, but some form of digital or cognitive training, which is tailored to particular brain circuits that might be, or cognitions that are impaired. Again, if we have an individual focus, we might do some neurocognitive battery ahead of time, and we'll say, hey, for you, in addition to being depressed, you have deficits in error monitoring or hyper error monitoring or working memory. And we know that these plastogens can induce plasticity and therefore might enhance cognitive training effects or meditation training effects. Lifestyle medicine, I already told you all about that. What's hard about lifestyle medicine? It's hard to get people to change their behaviors. So we have agents that can potentially enhance that or help with that. It makes sense to combine these. These are easy, scalable, low side effect interventions. Perfect. That can be coupled with, potentially powerful molecules that can enhance and result in enduring behavioral change. And then I'll just comment that some of what we work on, or I work on, is using animal physiology. And I talked a little bit about LFP, but one can imagine this with calcium imaging and all of these other approaches as a translational biomarker. So rather than restricting ourselves to forced swim test or sucrose preference test, maybe LFP or physiology could be another way to screen or test for compounds that can affect activity in a way that we think is relevant to humans because it's capturing the same exact physiological parameters that we see in both. So that's pretty much it. I think I've covered most of this, but how we think about psychedelic medicine moving forward is, well, right, I say it has to fit into this biomedical paradigm. I'm not sure if that's actually true. I think there's many models in which we could think about this, but at least one of those is maybe the question of how does it fit into our current biomedical paradigm of treatment. Thinking about that carefully and strategically now, I think, is better than, oops, we don't know what we should do now. We have 20 different psychedelic agents, and we don't know which one we should use when, which is kind of the situation we're in with SSRIs and antidepressants. So it should be kind of like informed treatment selection, ideally guided by electrophysiological parameters. This could be MRI, fMRI, it could be EEG. And I think really pairing it with approaches, no matter where you are, I think pairing it with approaches that are informed by psychology, that are informed by cognitive neuroscience, that are informed by the phenomenology of the disease itself will be important. And this is probably even more true for the non-psychedelic plastogens. Why do I think it's more true for that? Well, the psychedelics, you're already going to probably all of the models are going to be psychedelic-assisted psychotherapy. So you're already having a high-end, very expensive treatment. The psychotherapist should be doing a lot of what I was telling you about anyway. But for these other models, and I'll put ketamine in this category, where they're not traditionally or automatically coupled with psychotherapy, I think pairing it with these other approaches makes a lot of sense and could probably lead us to improved efficacy overall. So I'll close by saying, mental wellness, we think, should be delivered in some kind of closed-loop system with assessments and ways that we can inform clinicians and the participants, the individuals themselves. How are you doing? What's improving? What's not? How do we continue to move forward and iterate through that? And I'm done. So acknowledging all of the people who I worked with, all of the people, I have to say, most of this work was either led or co-developed and with Jyoti Mishra. She's the brains behind the operation, but all of the other people who worked with us were instrumental in every aspect of this. And as everybody knows, you're just one person and you can't really do anything without all of the other people who are contributing in all these wonderful ways. Also acknowledging the funding, and I think I finished just on time, which I'm amazed at.
We do have time for one or two quick questions.
First, thank you for your work. This is awesome to see biomedical studies with lifestyle-based things. Granted it's personalized, in the studies you've done so far, is there one activity that you're surprised has the most positive effect in your patients?
That's actually a great question, and we're early enough that if you looked at our trend, it looked like all of the interventions seemed equal right now, and we didn't know ahead of time what that was going to look like. I'll tell you what I was most surprised by is there was very, very big differences on an individual level on which was the top predictor. So when Jyoti first started doing this, I said, everybody's going to have the same model. Everybody's going to show that exercise and sleep and interpersonal interactions are all predictive of mood and positive. And that wasn't the case. We see very different models, very different top predictors. And that, to me, was the most surprising, is at an individual level, some people's exercise and activity didn't matter at all when we're developing that initial personalized model. And it was really all about their interpersonal interactions. And for some people, it went the opposite way. We would see models where the more social interactions they had, the worse they would feel. And so we were like, okay, these people should not have a, interpersonal intervention. And it was sleep or activity. So that was the biggest surprise, is actually there's a divergence in the prediction and the top predictors. But so far, what's interesting is once we match them, the effects have seemed reasonably similar and comparable.
It's awesome. It shows that pre-work makes all the difference.
Potentially, but we don't have the control yet. So I don't want to overstate it, but I do think it's probably important.
Awesome. Thanks.
Let's have one last question before the break.
I'm just curious to know if in this research there was race. I know age and sex is probably, but race as it relates to the interventions that are more preferred, and specifically thinking about BIPOC patients and how it could be possible that more physical movement to overcome some of the trauma that's embedded in the body in somatic ways can help. So I'm just curious to see if that was the case, if race was kind of taken into account, to see if there was specific modalities that were more preferred, interventions that were preferred.
This probably, you're talking about the personalized medicine, the behavioral lifestyle thing. No, we're way, way too early right now. But I think the idea of incorporating, there's just so many things we haven't incorporated yet. I mean, things like even at the level of sex, menstrual cycle things we haven't really looked at in detail. I absolutely think aspects of your own prior experience, so trauma and all of its elements, right? Racial trauma, childhood trauma, how do these potentially predict or go into what we should recommend? The good thing is, at some level, the model in theory should take care of these individual variations because it's not a model across people. We develop a model for that person based on what predicts mood in that person. So part of what I would say is your question will know if we are able to do a large study and start looking at, oh, look, it turns out that people of a certain experience or trauma history or race or sex actually end up being looped into, based on their own model, looped into one particular intervention or another. But we're hoping that because the model is just for that person, if there are these differences, we would select a model that is tuned to them anyway. But it could be also that maybe some models don't work for different people, and where would that lead us? And so there's a bunch of things we're not measuring. So we can always measure more, and that's probably my best answer is trying to think of all the things we should be measuring.